Welcome to the Wild Physio podcast with your host, Andrew Wild. Today, I have Dr. Peter Malliaras on, and he's a physiotherapist and researcher from Melbourne, Australia, specialising in tendinopathy. In 2006, he completed his PhD in tendinopathy, identifying novel risk factors, and since has undertaken postdoctoral research in the UK and Australia and has co-authored over 100 peer-reviewed publications. Currently, he is an associate professor at Monash University Physiotherapy Department and involved in multiple funded tendinopathy research projects in Australia and internationally. Huge welcome to Peter Malliaras. How are you, mate?
Very good, Andrew. Thanks for having me. Thank you very much.
Absolute pleasure. Really looking forward to it. Now, we're going to hit you with the yes, no, maybe questions to start with, which everyone hates, but I kind of love, and so do my listeners. So, you can only answer with a yes, no, or maybe. Are you ready?
Yep.
We'll dive into why after. Is tendonitis a poor word to describe a tendinopathy?
No.
Would you typically see patellar tendinopathy in a middle-aged woman?
No.
Are knee extensions a great exercise for patellar tendinopathy?
Yes.
If you have a diagnosed tendinopathy and you have seen a clinician and they haven't given you a structured, heavy, slow resistance program, should you see someone else?
Yes.
In regards to a tendinopathy, can the tendon pathology heal?
Maybe.
Should everyone do plyometrics for lower limb tendinopathies?
No.
Is patellar tendinopathy overdiagnosed and the diagnosis is often patellofemoral pain?
Maybe.
Yep. Should your rehab program be different for an Achilles peritendon issue versus an Achilles mid-portion tendinopathy?
Maybe.
Do you have to be an athlete that jumps regularly to get patellar tendinopathy?
No.
Are gluteal tendinopathies more common in postmenopausal women?
Yes.
Is PRP an effective treatment for tendinopathy?
Depends how you define effective. Sorry. No.
Cool. Does poor dorsiflexion range of motion and a rigid supinated foot increase the chances of developing patellar tendinopathy?
Maybe.
Last one. Will patellar tendinopathy clients usually have calf weakness on the affected side?
Yes.
Great. How'd you go? That's everything done.
Yeah. Look, I thought I would be more maybes, so that was good. It was interesting.
Yeah, cool. Ever started a podcast like that? I kind of like it because it's just like straight to the point.
Yeah. No, I haven't actually. I haven't. It's good.
Okay. Now first things first. Let's go through what an actual tendinopathy is. Fire away, Peter.
So it is a condition of pain and pathology in the tendon, and so pain that is localized to the tendon, and pathology is what it's characterized by. And often people have dysfunction, various levels of dysfunction, from just a bit of morning stiffness to severe inability to walk, run, or severe impairment of walking, running, and sporting type activities. They affect the upper limb and lower limb. Achilles is a common one. Shoulder tendinopathies are also common, but they are very, very, very common musculoskeletal conditions.
Now, in regards to the question I asked before, whether the pathology within the tendon can heal, dive into what we know at the moment.
We know that with a tendon, you've got structural changes. You've got the tendon structure is made of collagen and also other proteins within that tendon. And when you have a tendinopathy, you sort of get a change of all that structure. It becomes the collagen is less organized and inferior quality. You get more of what we call ground substance, which is water binding proteins. And that contributes to the thickening of the tendon. You get other changes in the blood regulation and ingrowth of blood and nerve vessels. So you get all these changes that happen. And from that pathology, it's not clear how pain emerges. So pain somehow doesn't really affect some people, and they have this pathology that they just have there and it's not painful. Other people, they do develop pain and they usually have this pathology as well. So we're not clear on what is driving the pain. It's certainly not the pathology per se, the tissue changes per se. It must be something underlying or associated with that, like biochemical changes. But when you talk about healing, people generally talk about the tissue. So the tissue returns to some state of normality. Now, we know that at best, the evidence we have at the moment suggests that at best that happens incompletely. So you may get to some state of normality of the tendon again, but it doesn't go back to a normal tendon for a vast majority of people. The reason I answered maybe to that question is because we do have probably some limitations in the literature at the moment. So we look at people mainly with ultrasound, and ultrasound is very limited because it doesn't give us that sort of very granular change that may occur on a molecular level in terms of getting back towards healing. So maybe there are healing or some level of healing, I guess we could say, for some people that we're just not picking up with the technology we have at the moment. Maybe there's also the problem of the tendon severity. So, for example, if you have someone who's got a less severe tendinopathy in terms of tissue changes, they're probably less likely to heal. They're probably more likely to heal than someone, i.e., again, talking about tissue as the healing, and then someone who's got a very severe tendinopathy, and they might have, what people would refer to as, hypoechoic areas or even delaminations and tears and things like that some radiologists report. You might be less likely to heal. So healing is really tissue-based, and it doesn't seem to happen for everyone, but it doesn't. The thing with healing, and the other reason I said maybe, is it depends on how you define healing.
Yeah.
If you define healing as improvement in pain and function, yes, you can heal. So that's what we tend to aim for, because we know that improvement in pain and function does occur.
Why do you think that some people develop pain versus others? So obviously people can have pathology on a scan. Some people have pain, some people don't. And they could have very similar amounts of pathology within the tendon. Why do you think some people get pain versus others?
It's a really good question. And it is probably one that we don't really know the answer to at the moment. So why some people develop pain and others don't, it is really hard to answer. It could be that some people are just genetically predisposed to have a tendinopathy that is going to go down a painful pathway. And that could be because of other factors that are going on. It could be that there are systemic factors in that person that, again, could be genetic, that mean that the milieu of biochemicals within that tendon are then going to result in pain, whereas for other people, it's different and it doesn't result in pain. It could be more related to how the processing of those of that peripheral input from that pathological tendon. So it could be more on a sort of central level, how those inputs are registered by the brain. It could be related, and that could obviously, interact with that person's anxiety and apprehension and the way they view the world, basically, and past experiences and all the things that we know about pain. So it could be more of a central processing level. changes or differences between people. Or it could be, as I say, more peripheral and depending on the biochemical processes that are occurring within that person. So it is difficult to say at the moment what the differences are actually between people who have pain and don't. But we know for sure that there are a large proportion of people that actually, if you image them, have pathology but don't really have much pain at all or no pain whatsoever, which is really interesting, but also consistent with everything that we see with musculoskeletal injuries and the fact that we are just beings that are just degenerating at a pretty rapid rate from whenever we're sort of past the age of 30, and there's not much we can do about that. Unfortunately, it's a steady decline, and the older you get, the more, decline. Degенeration's probably not the right word because it's a very highly emotional word and highly charged word, but we're not getting better with age, are we? In terms of our musculoskeletal tissues, we're not getting better with age, but that's okay. We might be getting better in other ways.
Speaking of words, so tendonitis versus a tendinopathy, because a lot of people walk in the clinic and they tell me that they've got tendonitis. Just let's go through the terminology, because I think that words definitely matter.
Absolutely. I absolutely agree. Words are very, very important. And that's what I was talking about with degeneration there. So you don't want to be talking about degeneration so much because people get the wrong idea. They think that this is something that they just cannot do anything about, and that's what you really got to avoid. With tendonitis, it does mean that someone has an inflammatory type problem. So tendonitis is inflammatory. So it sort of indicates that, this is an inflammatory problem, and this is the problem with tendonitis. It tells people that what you should be doing is just taking some anti-inflammatories and you're probably going to get better. But we know that that's not the case, and people will not just get better if they just take some anti-inflammatories. So it sort of leads people down a path of treatment that is not the correct path, and that's the problem with tendonitis. The other problem with tendonitis is we don't really have, there's debate, I guess, about inflammation and how much inflammation there is in tendinopathy. It's a very sort of polarizing topic because some people believe there's no inflammation, and other people believe that there's, it's actually an inflammatory condition. And the pendulum has probably swung from inflammation to no inflammation in the sort of past few decades, but now we're starting to recognize that it probably is an inflammatory problem, and there's really pretty good evidence now that there's inflammatory signaling and processes that are occurring within a tendinopathy. It's probably not the same as other inflammatory conditions, but it has its own inflammatory signature, and it is. But again, that's not to say that we should call it tendonitis and we should just give anti-inflammatories, because although it's an inflammatory condition, it's very much a load. The key factor for tendinopathy is that it's a load-related condition. It's not like you've got what's another example of an inflammatory condition that you can just treat with anti-inflammatories. If you irritate something and you get some inflammation of say, I don't want to use this example, but I will because I can't think of another one of a bursa.
Yeah.
Because
I knew you were going to say that.
Because you're rubbing it, then maybe some anti-inflammatories will help that. But because it's not so much you're loading a tissue, it's just that you've actually just acutely, but it is loading still because you're still rubbing the bursa with load. But it's an example of where if you modify your load and you also give some anti-inflammatories, maybe you will get resolution. But with a tendon, and with its surrounding tissues like bursa and paratendon, they are load bearing to a certain extent. So you do have to load them to get them to actually get them better. And
so typically you're going to be using tendinopathy as the word with a client rather than using tendonitis.
yeah, pretty much. So
Yeah.
I would always refer to it as tendinopathy and say, look, it's a pathology in your tendon that's characterized by pain and changes in the tendon. The changes in the tendon may get a bit better. The pain and your function, we can definitely get better with the treatments that we're going to do. So that's generally how I would sort of describe it to them.
Now, a lot of the listeners are physio new grads, physio students, and also people that are currently probably dealing with a tendinopathy themselves, and they want to know, what the hell should I do? What do you do with a tendinopathy of the lower limb, especially, say, the Achilles and patellar tendon? Do you want to focus on one?
Yeah, we could focus on one.
Let's talk about the patellar tendon.
Okay, so with the patellar tendon, generally, you would. So, are you talking more in terms of management?
Yeah. So management. How is the tendon pain that people are getting? Say, for instance, they're a 17, 16-year-old jumping athlete. They are a basketballer or a high jumper or something like that, and they're getting patellar tendon pain. What should they do to manage this? And I know this is an open-ended question because everyone is different, but as a general rule, what should someone be doing? And you kind of already answered it with the heavy, slow resistance stuff in the yes, no, maybe questions.
Yeah. So basically, probably the two most important things when you're dealing with a tendon problem is to be thinking about how much load that tendon is seeing. And so you're looking at how much load are you doing from it could be basketball, running, high jump, sprinting. And that's why I answered no to the jumping question, because with a jumping athlete with patellar tendon, because it can be a sprinting athlete. It's often not just a recreational runner, because they don't tend to be putting enough load into the tendon to get a patellar tendon, but they can sometimes present with patellar tendinopathy.
Is that because the load isn't fast enough?
Yeah, it's just that the patellar tendon, generally the higher load type activities like sprinting and also jumping. So high jumpers, basketball, volleyball, football, because they're doing a fair bit of jumping, fair bit of, especially ruck and key position type players, but also other players, because it's change direction as well. So it's change directions. It's anything fast, intense, change direction, stopping, starting, jumping, sprinting, as opposed to just plodding along and running. The only time that you get your recreational runners is if they're doing a lot of hill work or a lot of sprinting work as part of their training. But back to the question, if you're looking at management, you've got to look at all those loads, and then you've got to determine how much loading that person is doing that is affecting the patellar tendon, and then you've got to think about probably the first thing is to think about reducing the load to allow some reduction in pain. The most effective thing, people have pain, and that's why they present with these conditions. The most effective thing to manage someone's pain with a patellar tendon is to basically reduce the amount of provocative load they're doing. So that by far is the most effective thing. And so you've got to then look at the load and reduce it. My general rule of thumb is, if they're load intolerant, and that's what I define as having quite moderate to severe pain with general activities that load the tendon, like jumping, running, etc., reduce it by 50%. Reduce the load, that high intensity loading. So if they're running, if they're sprinting, doing 3 sprinting sessions a week, take 2 of them out. If they're really load intolerant, So they're reporting really, really high pain, just stop everything for a period of time. And that could be 4 to 6 weeks for most people. Allow the pain to come down, and then you can start to build them up again. So that's probably the first thing. And then the second thing is looking at the progressive loading. So then you're starting to look at, progressive loading for the tendon, for the muscle, to regain strength, to regain power. And you can do the progressive, the heavy slow resistance that you mentioned. That's probably the most probably fair to say it is the most effective. There was a study that came out last year which showed that it was superior to the centric approach that we used to use before that on a decline board. So that's probably one to go for, and that involves your leg extension, your leg press, possibly some squatting or some split squats or something in weight bearing as well, progressively increasing the load, relatively low rep ranges to get some real high maximal strength. Doing that 2 to 3 times a week is generally effective for a patellar tendon. So that would be the other thing in parallel. And if you do that for long enough, most people do respond. The problem is people tend to try and take shortcuts, and that generally involves things like multiple injections, relying on passive treatments, not load managing enough. So not really reducing their jumping or sprinting loads enough for long enough. Not doing the gym work intensely enough or progressively enough. And those things really are, common errors that you see and people just don't recover from or don't really get better. It's a hard injury to recover from. But then the last stage is also returning progressively back to that high load activity. So if you're doing sprinting, you're progressing back to the sprinting gradually, and you've got to break that up and slowly, incrementally get their load back up to where it should be. And that probably involves for most people a jumping program or a sprinting program or a change direction program or something like that. So that sort of, and that also is something that is often not done very well because it is a hard thing for most people to sort of. What's hard about it? I'm trying to think.
Hard to stick to because it's a long process.
Yeah, hard to stick to for sure. Hard to motivate yourself and the patient. But also really hard for, I think for physios generally, and for clinicians generally, the hopping stuff and the jumping is not really something that that we know about because we just don't have any guidance on it. If you look at the literature, there's pretty much no trials that do that end stage rehab, and we don't have any guidance on it. And it's a difficult thing for us to implement. So I think as clinicians, we find it hard to do because we don't know as much about it. Because everyone knows heavy slow resistance. Yep, you do this, you do that. That's fine. We can all sort of feel our way through that. But with the hopping and jumping, it's not as well defined what you do.
And how many times a week would you be typically performing your heavy slow resistance training for a tendinopathy, such as your patellar tendinopathy?
Generally 3 times a week, 2 to 3 times a week. So at the start of your rehab, maximum of 3 times a week at the start. And then as they're starting to do more things like a bit of running, and then a bit of high speed running, and then maybe some jumping, depending on what sport they're doing, then you might reduce it to twice a week and then eventually to once a week as a maintenance during the season.
And in regards to those 2 or 3 sessions, you're obviously splitting them up over the week. And this segues into my next question. How long does it typically take a tendon to recover from a lot of loading? And that would be either loading in the gym with that heavy slow resistance or jumping load, e.g. dunking a basketball or doing some jumping based loading as a high jumper.
So generally, if you're looking at loading in the gym, it recovers quite quickly in terms of pain. So in terms of pain, you're looking at most people have minimal pain when they're doing gym stuff. And this is something that is often surprising to people because they think, oh, if you're going in doing leg extension or leg press as a very high load activity, you're probably going to have a lot of pain after. And the reality is they sometimes have pain during at the start of the rehab process, but after about a month, they generally don't have any pain with it and they can do it easily. Where they do have problems is when they're doing their jumping or running. So with that, with the rehab process there, generally they'll start that at some point during the rehab process, could be a few weeks in, and they'll have some pain with it. And the pain, that's when you need to monitor pain, make sure that they're having minimal pain with those activities and that they don't flare up too much after. So it's the after effect that you're really interested in, and you're interested in what's their pain like that evening, the next day, what's their pain like by the time they do their next rehab session the next day, or by the time they do their next jumping or running session 2 days later. And you want to make sure that they're not overall increasing in terms of their symptoms, they're moving in the right direction. So that's very important. So yeah, it's the flare up with the high load activities that is really important to monitor.
Yeah, it sounds like monitoring, because I tell this to my patellar tendinopathy clients or any tendinopathy client, the pain during, after, next day is important. And so segue into my next question. Do you have to have pain during a tendon rehab program, e.g. in the gym? Is it better to have pain or no pain, or where are you at with that?
Yeah, it's a good question. It's because we did initially with the Alfredson approach, and people would remember the Alfredson eccentric approach, that very much was a program that was, you need to have some pain. So you want to push into some pain, and that's what we were driving for. But now we sort of, that's not really so much the case. It's about building tolerance and strength. So the rehab is really designed to recover function, so build capacity in the muscle and the tendon, and also to then, it is designed to improve pain, but how it improves pain, or if it actually is the mechanism for improving pain, is not really clear. I don't think you need to have pain during it, as long as they are progressing and reaching targets. But I think it is important to have functional targets. So for a patellar tendon, I would always set functional goals. So for example, leg extension, they might start at 30 kilos, they need to get to 60 kilos. Leg press, they might start at 50 kilos, they need to get 120, 130 kilos. Something like that, depending on the athlete, depending also on the machines they're using. But they don't necessarily need to be painful when they're doing the exercise. Now, a little bit of pain and dealing with a bit of pain during the exercise is fine. That it's okay to have some pain, but not pushing into pain.
And with a knee extension exercise and or say a split squat or something that's single leg, are you preferring to do these exercises single leg? Because typically a client's going to have a patellar tendinopathy on one side, not bilaterally. Are you doing your knee extensions unilaterally or bilaterally?
That's a good question as well. So basically, you can do it preferably single leg for everything, because you're assuming that there maybe is going to be some impairments that are not symmetrical. So they might have, they might have a, let's just say they've got, on their affected patellar tendon, they've got reduced capacity in that quads, but on their opposite side, they've got a previous ankle, whatever it is, fracture, and they've got weakness of that ankle that's asymmetrical. So then it is important to do unilateral exercise, but the thing that is, the problem with unilateral exercise, the only problem with it is that it takes double the time. So you have to do everything on each side.
Yeah.
So in some patients, I guess the best exercise is the exercise that the patient actually does. So sometimes you have to compromise. And I do find myself with some patients, if they've got limited time, if they tell me I've got 15 minutes or 20 minutes a day to exercise, then you're going to have to do double leg for some things. So you might do single leg for exercises where you think there's clear evidence of an asymmetry, but you do double exercise for the other ones.
For sure. And you've mentioned in the yes, no, or maybe questions that typically on the side that someone has a patellar tendinopathy, they are going to have calf weakness. So obviously calf loading program is important on the affected side. What type of exercise are you typically giving to people for their calf?
So generally they will have, if they've had, I'll just clarify that answer a bit. So basically they will have, if they have had it for a long time, they've generally got unloading throughout the whole limb. So they're probably going to have some weakness areas in that whole limb. So that is a good thing to look at. And I generally do some seated and standing calf raises, a combination of seated and standing calf raise for most people if they're in the gym. Otherwise, if they're at home, you can just stick with standing calf raises as long as you're loading it progressively.
Sure. And you've mentioned before that the plyometric side of things, not everyone should be doing plyometrics for a lower limb tendinopathy. When are the plyometrics important for a lower limb tendinopathy?
So generally people who are going back to running, they are a really good candidate for some plyometrics for, say, the Achilles. Someone who's going back to jumping, sprinting, they need more progressive stuff. Like when I think plyometrics, I generally would think sort of low intensity jumping, hopping type interventions like box jumps and hopping, submaximal hopping. You can do obviously more progressive maximal jumping, but I'd probably classify that as more jumping because plyometric is defined as continuous jumping. So it's not really the jump, jumping is separate because you're sort of jumping and then stopping.
So we're thinking with a plyometric, it's more short duration, short contact time, something like, a hurdle hop or a depth jump or something like that.
Yeah, exactly. Yep. All that sort of stuff. But it can be maximal. Having said that, it can be maximal because we often do like triple jump for distance, and that is a maximal activity because you're landing and then as soon as you land, you jump again. So it's a maximal plyometric activity. So you do get to maximal as well. But I guess for the Achilles patients that are going back to running primarily, you want to do submaximal because that's all they generally need. Maybe a little bit of progressive submaximal, but I've got a hopping program that I use for Achilles patients and runners. But then for your jumping and sprinting, patellar tendon change direction, then you want to have a bit more of a progressive program where you're doing some maximal plyometrics, some maximal forward hops perhaps, but you also do some change direction and some high speed running. So the plyometrics can be useful for, I guess, mainly patellar and Achilles, particularly if they're going back to running. But any athlete that I see is going back to running, they will generally go through a hopping program as part of that as well.
When's the highest amount of load on the patellar tendon throughout the jumping and landing phase?
Generally, that's a good question. It's generally when they are in the highest ground reaction force or close to it, and that is when they're in the deepest amount of knee flexion. So say if you look at a hop, when they go into that knee bent position and they're going from eccentric contraction to concentric, that's the point when ground reaction force is greatest, and the knee tendon load is greatest close to, but not exactly at that point. So that's generally when you get the highest force.
And there's less load when you land, is that correct? Comparatively to that position?
Less load when you land, yeah.
Yep. Okay.
Yep.
What are your thoughts on depth jumps? So especially for someone that's a basketballer or someone like that, and depth jumps from a decent height, because it is very much, a shock method type of plyometric. What are your thoughts?
Yeah, I think it's fine. You've got to be careful of the time that you bring it in, because it can be quite provocative. It's also it also brings me to the sort of thinking of um, the much maligned physical activity that people tend to enjoy. Just got a mental blank now. Um, Lots of people do that physical activity where they jump and with heavy weights on their back, and they do it deep. What's that training called?
A CrossFit.
CrossFit. Thank you. I just had a mental blank. So it takes me to that sort of thinking. So CrossFit is great, and physical activity, great, really good, ticks all the boxes. But if it's not done in a way that is structured and progressive, you can get people who are loading. If you've got the combination of plyometric load into deep knee positions, that can be really taxing for the patellar tendon, because you've got a high load, plus you're also going into this high force position because you're in so much knee flexion. It's good, and you potentially can be really good for it, but it can also be provocative. So you've got to be careful. My rule of thumb is be careful about going beyond 90 degrees of knee flexion.
In regards to weighted jumps, do you think it's necessary to weight jumps, especially if you have a client that has a patellar tendinopathy?
I don't think it is necessary to weight jumps. It can be a good way to develop power. It can be really useful for power developments and for strength development, but I don't generally find it. I don't think it's necessary. I don't think it's necessary. Maybe for some athletes, if real power athletes may get benefit from it in terms of training and muscle development, but I don't think it's absolutely necessary. I do a lot of velocity-based training, which is trying to get concentric peak velocity when they're doing loaded activities. So, they might be doing things like some calf raises, and they're getting to a point where their strength is good, their maximal strength slowly is good. You can then start to increase that and progress that by doing sets where they focus on concentric velocity and slow eccentric, and that's quite good. But I don't tend to do jumps with load.
Great answer. Now, if someone had a patellar tendinopathy and they were a basketballer, would there be a certain amount of jumps you would be limiting them to during their training sessions as you start to return them back into training in games? Obviously, you can't limit it in games, but during training, is there?
Yeah, I think you've just got to be mindful of what type of training they generally do, and what you've got to, I guess that's the question then sort of goes to, what have they done in their rehab to build up? So I would generally have a block of jumping where they would progressively build the volume and the intensity of the jumps they do within rehab. And then they would get to training, and they would try to then replace whatever block you've done from a rehab perspective with a similar volume of training. I don't generally count how many jumps that is, but as long as it's a similar volume of whatever they've told you they do in training to what they've been doing with you, and then you can start to build the training volume towards their goal of training. As long as that goal of training is sensible and they're not sort of training themselves into the ground with the stuff that they're doing with their coach, then that is sort of the approach that I take, rather than actually counting the number of jumps.
Yeah, you're just really trying to manage any big spikes in load. That's what you really want to do. You don't want to see huge spikes in load. And you typically see that with your jumping athletes around that sort of 14, 15, 16, young adolescent men. They start to do more time on court. They've got more rep trainings and all this type of stuff, and their patellar load goes through the roof. Now,
Absolutely.
Then that leads me into this, Peter, is why do you think that patellar tendinopathy is often overdiagnosed when often it's actually patellofemoral joint pain that people are getting? because I see it so often. People come in, they're like, I've got patellar tendinopathy, and they're not a jumper, they don't run and sprint, and they're a 36-year-old female, and you're like, look, you probably don't have patellar tendinopathy.
Yeah, I think I agree. It's really common. It's people just don't understand the difference. I think some clinicians will struggle to differentiate them, and it is not. There's a bit of daylight. Well, I shouldn't say daylight between the two conditions. They can be confused. There's definitely cases when they can be confused, but patellar tendinopathy presents as very localized pain right at the inferior pole. Patellofemoral joint doesn't generally present that way, and that's the most important differential. And that just knowing that for a lot of people. But if someone has localized pain anywhere near the patellar tendon or the fat pad, people tend to assume it's patellar tendon, whereas it's often not, because it's got to be right on the bone, i.e., right on the insertion of that tendon to the inferior pole of the patella. If you've got a point of pain in the fat pad somewhere, that's probably not patellar tendinopathy, and I think that's where the confusion comes from.
But also, a lot of people will tell you the diagnosis as well, purely by the subjective examination. If someone's not sprinting, if someone's not jumping, playing a change of direction, jumping-based sport, they probably don't have a patellar tendinopathy. And it's also more common in boys. It's typically a male-dominated diagnosis. Would you agree?
Yep. It's you do see it in females as well if they're doing those sports. But you're right. The other big clue is what sport they're doing. You don't generally get patellar tendinopathy if you're not doing those types of sports. I have seen, having said that, quadriceps tendinopathy in people who are relatively sedentary, and I'm talking about menopausal, perimenopausal females. They can get that, but it doesn't seem to be that patellar tendon presents unless you're doing sprinting, jumping, change direction.
Last question, Peter. Let's dive into PRP. So many people that have a tendinopathy come and see me and they're like, what are your thoughts on PRP? What are your thoughts on PRP for a tendinopathy, whether that be an Achilles or patellar tendon? Let's focus on those two.
PRP is a very compelling story. You get this biological agent, you take it from the person's own body, it's safe because it's from your body, it can't harm you, and then you concentrate all the growth factors which are in the blood, which are all your growth factors, and then you inject it into the tendon and it's going to heal the tendon. It's just such a good story. And such a good selling point. But the unfortunate part about it is that it doesn't work as the story would suggest it does. So for most people, the evidence, clinical evidence, i.e., does it help pain and function, suggests that it probably doesn't. If you look at the strongest and the best clinical evidence, do much over placebo. And then you can look at it also from a point of view of anecdotal evidence. And I've certainly seen a lot of patients who have had it, and it's hit and miss. And then we don't know whether it's placebo or natural healing or other factors with anecdotal evidence. But certainly in terms of my practice, I do still have it on the pathway of things that they can consider. I think as an evidence-based practicing clinician, you sort of have to, you can't ignore it. It's part of the landscape of what we do, and it's quite popular in a lot of places. I generally in the first session go through all their options, exercise, the benefits, and the fact that exercise evidence is strong, but doesn't work for everyone. Then we go through all the adjunct treatments, and we go through injections and steroid and PRP, and I even talk about surgery briefly. And I just try and go through the benefits and the harms of some of those treatments. And So we do talk about PRP, and I often just say, look, the evidence is not really that strong or compelling, but it is a last resort and something you can try if you're really struggling. And some of my patients do try PRP, and that's fine. They, I wouldn't. I think it's up to the patient to decide once you give them the evidence of, what, in an unbiased way of what it is. So I don't think, I think a lot of the times physios can be seen as, never have surgery, never have PRP. It's not for us to decide, it's for patients to decide. We should be giving them the evidence and in an unbiased way. And letting them decide. So that's what I try and do. And some patients, they go for PRP, and that's fine. And it's, I use a lot of shockwave therapy in my practice, and it's no less or more evidence-based than shockwave is. Shockwave is also has question marks over placebo. And when I use it, I tell patients, I say, look, I'm going to do this treatment, might help your pain, but we know that for some studies, they show it doesn't really work that well. Do you want to try it? And it's up to them then if they want to try it or not. So I'm really strong believer in letting the patient decide where they want to take the treatment, rather than us saying, right, you've got to do this, you've got to do this, you've got to do exercise. Even with the exercise approach, we've got to be saying to people, this is probably something you should try. Most people do get benefit, but not everyone will improve with exercise. And then also giving them the choice of what exercise to do. So what exercise is going to fit in with your life? And I've probably improved on this. I was pretty much, I guess, very committed to the heavy, slow resistance, and I still am. But that's my preference, and I sort of argue it based on not so much the pain and function benefits, because there's no clear pain and function benefits when you compare it to other exercise treatments, but there might be functional benefits. I do believe that people will get stronger faster if they do a gym-based program, as opposed to doing, say, a program that is a home-based program. So I can sort of argue it and rationalize it in that way, and again, present it to the patient. But I think ultimately the patient needs to decide where they want to take it.
Really well answered, mate. I think we need to be less like a dictator and give the patient all the available options. And yes, I agree. Then they can make the decision based on what you give them. So completely agree. Now, Peter, thank you so much for your time. It's been really, really great. I think all of the listeners will gain a lot of knowledge out of this, especially the new grads and the students. Now, where can all the listeners find you? Instagram, website, that sort of stuff?
Probably the best place is our website. So it's tendinopathyrehab.com, and I basically do it. I've got an online tendinopathy course. I also do face-to-face course, but I haven't done that for a year and a half now. Just on Twitter and Instagram, usual places as well.
Sounds great. This podcast is live on Google Podcasts, Apple Podcasts, and Spotify. Any final words, Peter? Bits of wisdom?
Just take your time and enjoy it, basically. And thank you very much, Andrew, for having me on.
Absolute pleasure. We'll have to do it again soon. Thoroughly enjoyed it. Thanks again. As usual, guys, stay strong.